Well, welcome to Day 3 Articles in Review. This is Mary Coughlin, and I'm presenting to you from my living room because it is still too cold to go outside. But I promise you will see some sights of Boston before the 12 days are over, okay? So today's topic, the articles that I've selected, are looking at pain and the implications of procedural pain specifically and long-term outcomes. This is not new, the information that I'm sharing you, and it's really a wonderful time to be in neonatology because, research is being discovered, new, insights about how pain is perceived, how pain, behavioral expressions of pain don't necessarily correlate with cortical pathways of pain, and just really great information that informs us. And so, the articles that I chose was this first one kind of just to set the stage. This is Ranger and Grunow from 2014. The title of the paper is Early Repetitive Pain in Preterm Infants in Relation to the Developing Brain. And what they were able to demonstrate is that indeed there are correlations between specifically white matter, compromised white matter development in infants with repeated procedural pain that is inadequately managed. And so what we know now is that these painful experiences actually cause a myriad of responses at the neuronal level, changes in metabolic activity, changes in oxygenation, and things that actually exert external forces on the proposed developmental pathways of the brain. So this is not new information. I mean, gee whiz, it's 2017. We've known that infants experience pain since the 80s, and yet we continue to struggle with the consistently reliable management of specifically procedural pain. This is obviously not the only form of pain. We have surgical pain, where we certainly have opportunities to improve on, as well as chronic pain, that disease-related pain that is just, you're in a constant state of distress, discomfort, and pain. But a lot of the research right now is focused specifically on procedural pain. And most recently, I just discovered these two papers from 2017. And there's been some work over in the UK looking at this, that again, we rely heavily on behavioral expressions of pain, right? We look at vital sign parameters, and we look at behavioral cues, specifically facial movements, grimace, nasolabial fold, crease, and that sort of thing. With or without a cry, we look at extremity movement, and all of these indicators that tell us the baby is upset. And if we're sticking a sharp needle into them, it's probably because of pain. But what we're also discovering now is that these expressions of pain can be individually different, right? I may cry at this pain level, but you may cry at a different pain level. And the same thing they're discovering with babies. And in this one study from Archives and Diseases of Children, Fetal and Neonatal Edition, Mader et al. Looked at the presence of cry and the amplitude, and is it correlating with cortical processing of painful stimuli in term infants. So the setting was a newborn nursery. They looked at these babies, they had them all hooked up to EEG and did simultaneous audio recordings with the EEG, tape rolling, if you will. And what they discovered is that a cry, the amplitude of the cry, doesn't correlate with the cortical processing. So what they're left to say is that discovering this, and this is something that people have been asking for now for a couple of years, are we really using the best assessment tools to determine whether or not an infant is having pain? And certainly, you can always improve upon things, but I think we're getting to that point where the resounding answer is behavioral is not enough. We need to go to that next level. We really need to do brain-based assessments of procedural pain. And certainly not to prove that we should be managing the pain. We should be managing the pain. And, the lack of management, or the lack of consistent management, really kind of speaks to some of the things that I've talked about yesterday around compassion care and compassionate care cultures, and how do we approach care consistently and reliably so that the infants are receiving high quality care. We know that the work of Monterosso and his team, that babies that received high quality developmental care specifically around pain management actually performed better than at 3 and 5 years of age with language skill acquisition and health related quality of life, and that infants that had poor infant pain management had a higher, demonstrated a higher incidence of internalizing behaviors at 18 months of age rather. And those behaviors are associated with psychopathologies, with depression, anxiety disorders, and that sort of thing. So we're seeing connections. We're seeing connections behaviorally, long-term, associated with long-term outcomes. We're also, learning more about the connection, the neural processing of pain, the cortical processing of pain. And this one very interesting study from neuroscience, this was from Chow et al. They looked at this factor called brain-derived neurotrophic factor, BDNF, and they specifically looked at this variant of it, which was really interesting. What they discovered is that their findings showed lower brain-derived neurotrophic factor available and a vulnerability to neonatal pain in boys, but not girls. And again, so there, people are exploring this to really understand the pain experience. It is nuanced, it is individualized, but those factors are just additional information for us to really more accurately understand the experience of the infant. It doesn't mean, well, boys, we have to be more attentive to boys' pains than girls' pains, or, we have to worry about the cry, or we have to worry about all these things. What we know today, and it's wonderful that people are doing more research and informing our practice for tomorrow, but what we know today is that unmanaged procedural pain is associated with short-term and long-term consequences. Just aside the fact that it's the wrong thing to do, we need to get all on board. So I know as individuals, you're very attentive to managing the pain for your patients, but we need to really expand that and really transform the culture of how we're managing pain consistently and reliably. And I know there's lots of enablers to that, and there are barriers to that. We work in a multidisciplinary environment. We have different, from a nursing perspective, we have a different sense of our autonomous practice in nursery A versus nursery B. But we need to peel away from that and really rise above to the best professional clinician that we can be, that we know we are. And through courage, through commitment, and through compassion, identify what is the best practice, what is that thing that needs to happen all the time, and begin your journey to transform that practice and make that an always event. The right thing, the right pain management for the right procedure at the right time, every single time. That's the stuff that I am passionate about. That's the work that I do with NICUs and clinicians all over the world. If you stuck and you want some ideas, please sing out, email me. You can connect with me through my YouTube video link that I upload these videos on, but you can't not do something. That is not an option. And you can't unhear or dismiss the available evidence. This is not made up stuff. This is reality. We are human beings. We feel pain when painful things are performed on us. And we know that these experiences they're adverse across all patient populations. But in our most vulnerable populations, the deleterious impact is so much more pervasive. So that's it for today. I will share the references, the citations rather, for these 3 articles. If you're looking for some more stuff, just sing out. I am compiling a best of references for 2017 across each of the core measure categories, and certainly pain and stress is one of those, and I look forward to sharing that with you after the new year. So take care, and I'll see you guys tomorrow. Bye-bye.